Good evening, everyone, and thank you for joining us for you event. Tonight, Dr. Shane Kanar is going to be speaking on pharmacological treatment of presbyopia, current and emerging therapies. I'm your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Lens Therapeutics for exhibiting at this event. We'll get to hear from them at the end of the presentation. So please be sure to attend for that, and we can. Next slide. There we go. So this will be with 1 hour of Shane Kanar is a managing member of the Kanar Eye Care, a clinical investigator and optometric educator based in Pittsburgh, Kansas. He has practiced optometry since graduating from UMSL in 2000. After practicing in a variety of practices, he returned to Pittsburgh with his family and opened Kanar Eye Care in 2009. It has grown into a six-doctor, four-location practice serving Southeast Kansas. He is directly involved in clinical care and serves as a managing member. Along with patient care, he has become involved in clinical research, having served as a principal investigator in over 200 clinical trials, including pharma, contact lenses, and devices. He's also one of the founding members and president of the Eye Research Associates, a clinical research group. Dr. Kanar has lectured regionally, nationally, and internationally on a variety of topics with an emphasis in ocular disease, practice management, and contact lenses. Along with this role, Dr. Kanar has served in an advisory role for a variety of industry partners and is the Vision Source Administrator for Southeast Kansas. Dr. Kanar currently serves on the Kansas Optometric Association Legislative Committee, and he is hot off the airplane from one of his trips speaking as well. You spoke in California, you said, I think, right?
Yes.
Yeah.
Mm.
So here are his financial disclosures, all of which have been mitigated, and I'll have you take it from here.
Well, thank you very much. And thank you, everybody, for making time to be here and being involved and actually wanting to learn about this topic. I really think this is an exciting and important time for us in eye care in general. There's so much opportunity for us, not only to meet and exceed the needs of our patients, but it's a time that we're seeing our lifestyles change and what we can do and what we can offer our patients dramatically changing, which really creates an exciting time for us. As was mentioned, I have been clinical investigator in multiple clinical trials, including in the presbyopia space, and I can really see the benefits that do arise for our patients when we use these type treatments and use this methodology. You know, really, what do we want to focus on tonight? What do we want to learn? What do we want to gain? And I think maybe the first thing that we can really talk about is, are we hearing what our patients are saying? And I think that that's a disconnect in this space that we miss a lot. And I want to delve into why I think that's a disconnect, what's happening, and what we can do to better improve that. And we really are at a point in time where we need to start to differentiate what are the different drugs that we have available for the pharmacological management of presbyopia. Why would I choose drop A? Why would I choose drop B? We really got to that point where we now have options, which really changes how we approach things. And then finally, we have to understand, what do we need to do for these exams to mitigate the risk for our patients as they exist, to better prepare our patients for success, and really to move our practice into this direction. So, three key learning objectives that I feel that we'll get into tonight. First of all, we need to talk about the growing presbyopic market. Why does this matter to us? And what are the impacts that it could have directly on our practice? Presbyopia is growing. I think it's, to me, almost overwhelming when we think about the fact that there's 120 million, 128 million actually, presbyopes in the United States alone. 128 million presbyopes. We're going to spend well over half of our life presbyopic in many cases. That's an incredible thing. It's a wonderful thing as we've seen longevity improve and quality of life improve, but this is a real condition that impacts our patients throughout half of their life. And it has an impact on so many things that we do routinely. When we really delve into what's happening in our lives, what's going on, one US study now shows post COVID, the average US adult is spending 13 hours a day on a screen in arm's length. And we're seeing that evolution occur, right? Not only in our presbyopes, look at the increasing, what some people consider pandemic rates of myopia and all those changes that have occurred and are continuing to occur for us. Our world is shifting for many people from a distance centric world to an intermediate world and near. And I can tell you, it's not the lights that's making my hair look this white. At 54, I am a presbyope. And my hair turned gray in my early 30s. And that bothered me a little bit, but nothing is as bothersome as being at a point in life where you have to turn on your cell phone light to read a menu or put on readers to do everything. I think we often have a disconnect. It's like anything. If you're a mechanic and a car breaks, it's an everyday situation, but to you, it's a mode of transportation. And if you're a patient who needs medical care for the flu, or maybe even what would be considered somewhat of a routine condition, when you're the sick patient, it's a dramatic thing. And the same happens to presbyopia. We deal with it all day long. We focus on it all day long. It's become commonplace for us, but it's not commonplace for our patients. It's truly not. And it is a wake up call that exists. And so many of your patients will talk about falling off a cliff. I'm obviously well versed in what's going to happen to the eye and vision as I age. But I can remember distinctly, I was doing something at my house under the cabinet, and I could no more see the type of screw that was on there without a bright light and some magnification. And to me, it felt like I fell off a cliff. And we're going to dispel that myth a little bit because that's really not what happens. But we all have that tipping point. And anti-aging is a big thing in our society. Just look at the sheer volume spent in clinics with anestheticians, with online. Nobody wants to feel older. And really, we'll mention it later, but 50 is the new 39. And our lives are changing. Now, this may all be mental, but I think of my parents at 54, and my life is definitely much different than theirs was. And what's even more important is what do our patients want out of their day-to-day vision? And I think we need to talk about that a little bit and get into the detail of that. Not only do they not understand what's happening to them, they're not aware of the choices and sacrifices that exist. So what do we do? How do we prepare a strategy that really allows us to succeed? And I think maybe the most important thing that we can get to, and maybe the key driver, is rudimentary as it sounds, is we have to engage our staffs. In today's busy clinics, we are all seeing more and more patients in order to continue to grow and survive and all those things. And our staff spend not only more time with our patients in many cases than we do, they're also the entry and the exit point in our offices. So if you want to drive this treatment, you need to sit down with your staff and talk about how it works, why it works, and most importantly, what's that a patient experience like. And we'll delve into the things we need them to know. But once you have that foundational approach in place, the next thing we need to think about is external marketing. It is a new space. I'm aware that we've had direct to patient marketing exist before. We're going to see direct to patient marketing exist in the future. Our patients are going to be asking questions, and first and foremost, we want to separate our practice by letting them know that we're the resource that exists. In experimental marketing, you have to make it an experience. And this is a great opportunity for many of us to separate our practices. And we'll talk about that and the value to your practice a little bit. But not only is it a value to your practice, I think it's also a value to the practitioner that shouldn't be overlooked. Your job satisfaction, your quality of life becomes better the more you're engaged. So talking about the front desk, it does have to be everybody working together. And I think the things we need to think about, how do we engage patients? How do we train our staff? First of all, we need to understand, and our staff needs to help us question what is the patient's primary concern. If I'm a truck driver, my concern may be different than if I'm working in data entry, or if I'm an eye doctor looking at a screen in a dim room all day. What is really driving our need? Our pretester should continue that discussion and it should flow through. But I think what's most important is having this clear, consistent message that says, we understand it's a problem. We're not dismissing you. We understand that you need a variety of methods to address your needs, and we're here to give you those options. And I think options become such a great word because uh, I've, I've heard a good friend of mine on the podium, and her comment was, "This is not an and solution or solution. This is an and solution." Sorry, as I screw up my quote. This isn't, we're going to give you solution A or solution B. It's not or, it's and. And when we think about that, it was just mentioned that I gave a talk in California last night. I got up this morning, I worked out. I was supposed to be on two flights. Flights are delayed. I worked on my iPad the whole time. Got on the plane, checked out a little bit, landed. I live 2 hours from the airport I was at, had to drive home. It's dark. I'm going to give this presentation. I'm back on a screen. I'm going to go home. I'm going to talk to my family. Gosh, that's a lot of activities in a day. And I think we mislead ourselves thinking that there's one true way to address our patient needs because there's no one problem. And we also short sell our patients thinking that they can't make those choices once we provide those options. So creating an experience, um, that becomes such a driver and a key story. And these numbers are about 2019 numbers, roughly. So realize they've probably escalated a little bit since then. But what is that experience worth to our patients? What does it mean to them when they come to their office? And what is the experience? Well, it's feeling engaged. It's feeling like somebody's listening to your needs and making you feel special. Starbucks is a wonderful example. If you grow a pound of Colombian coffee and you're the farmer, you have about $3 to $4 worth of value in that pound of Colombian coffee beans. Well, that's good. But then if you are the makers of Folgers and you take that same pound of coffee beans and you put them in a red can and you put them at the store, well, now we have a $10 to $12 value in that 1 pound of coffee. But if I take that coffee and I take that 1 pound of beans and I sell it to Starbucks and they create an experience, they can brew that 1 pound of coffee out. And with their experience, they generate over $350 in revenue out of the 1 pound of coffee beans. Why is that? It's because of the experience that our patients have. And we need to be aware of that when they come to our clinic. I read an interesting article a while back. It was been several years ago, but every dissatisfied patient tells seven. Every satisfied patient tells one. So when we think about it, we're already in the hole. We already have to create more satisfied patients. But what about the neutral patients? What about the ambivalent patients? And we're in a world today where our patients are bombarded with opportunities to select our eye care. Not only that, they have these provider manuals and they're trying to figure out who provides for their insurance. And yes, that matters. And where should I go for my appointment and what's happening? Well, that neutral patient in many cases is going to be trying to look at making a decision at night at 10 o'clock when they've ran out of contacts, or at night at 10 o'clock when their eyes feel tired, or when they're in a meeting and they're struggling to see the PowerPoint and they don't know what's going on. That neutral patient may not say negative things about you, but they're also not feeling an attachment to your practice. But what about the patient where we create an experience, where we've identified their needs and they have a positive experience? Not only do they create referrals by telling other patients about you, they're locked into your practice. And on the back end of that, they're much more likely, in our experience in my clinic, if we're managing the patient's experience, it's the best argument we have to keep the patient engaged in our practice, both for their clinical and material needs. It creates loyalty to our practice. Those positive patients are our driver and the best marketing tool that we can have available. I bring that up right off the bat because when we talk about the pharmacological management of presbyopia, I have so many doctors ask me, well, how does it fit in my practice? Am I threatening the other modalities I have available? Am I threatening contact lenses? You're not. By creating this experience, you're creating more profitability in that patient and more patients that exist for you. I mentioned there's 128 million presbyopes in the United States. There's well over 30 million that are treating their presbyopia simply with over-the-counter readers that they are unable, or not unable, they choose not to go out and get eye care. Those patients have a real opportunity to experience this experience, but it also becomes a real opportunity for us to identify many conditions that can be life threatening, such as macular degeneration, glaucoma, lifestyle impacting, such as dry eye, MGD, or systemic disease, such as diabetes, chronic cardiovascular disease, and in our emerging world of technology, kidney disease and other conditions. By tying these patients to our office, by helping them choose to select eye care, it's a chance for our practice to grow. So I wanted to get off the table right away the benefits of the presbyopic treatment of, or the pharmacological treatment of presbyopia. It is a real game changer for our practices, and we have to get past that uh, profitability per unit and look at the overall growth and longitudinal growth of our practice. So how do we create that experience? Well, obviously superior service. What's their wait time? But all those things, superior products. I think those are kind of givens for us. But the last two is where I really want to delve into it, and I think really becomes important. First of all, is patient communication. You know, I've yet to have a patient leave my practice because I presented them options that they didn't think would work for them. I think by remaining cutting edge, by talking the patient through the opportunities that exist, by working with them to select what they need, we create that experience. But I also think it becomes very important to communicate with the patient and be a listener and hear what their needs are. So maybe their glasses work just great when they're at the desk, when they're functioning all day in this space, but not when they're jogging, not when they're playing golf. What patient problems do they have? And continuous improvement. You know, if I'm going to be on my soapbox for just a second, I have practitioners asking, and I hear them talking, okay, but what about these opportunities to not get eye care and buy your products just like the readers? The best way for eye care to continue to grow and not be replaced by algorithms and vending machines is not to perform like an algorithm or a vending machine. Use critical thinking, continue to improve what offerings you have for your patients as well as what they have. So eye care is a service industry, and we want to choose to offer our patients the most and the best opportunities that exist. We can delve a lot into patient communication, um, but I want to talk about what does that look like, and what is how do I want to say this? How do we identify presbyopia becomes the biggest element that I can think of. And by that I mean this: if I do a survey of 100 eye doctors, and I just did this at a discussion, there were 40 people in the room, and I said, tell me, if I ask you, is blur at near the beginning of presbyopia? Just about, and this was an OD ophthalmology group. They were all like, yeah, presbyopia is blur at near. That's the first thing we think about. But we need to really begin to remember presbyopia is a weakening of the muscles. I love to lift. I may be able to lift what I could 10, 15 years ago, but I'm so fatigued it takes me forever to recover. When I'm becoming presbyopic, it's the accommodative system working, and I may be able to get by and make that happen. But as I do, those muscles fatigue earlier. So really, early presbyopia is not blur at near. That's intermediate presbyopia for most of our patients. Early presbyopia is, gosh, if I focus on a near task, it starts to blur out. If I've spent all day on a screen and I look up, it takes so long for that process to work or to relax. At the end of the day, I can't focus up close anymore. That's early presbyopia. And those are the questions we should be asking our patients earlier in their age. And then we need to relate the opportunities we have for them to their products that are available. I've kind of talked about this. There was a committee formed similar to DUES, and they defined early presbyopia as up to plus 1.25. So plus 75 could be early presbyopia. I'm a big believer in doing Jackson cross cylinder at near on A, younger patients, and then B, that 35 to 50-year-old range. It really, I think, helps us delve into what's going on. Your vision drops to 2025 to 2040. That 2040 is a big mark because that's really our functional vision point. 2020 at near is a rare ask for most of us anymore. Mild presbyopia plus 1.25 to plus 2. Near vision be 2050 to 2080, and then advanced is plus 2 or above. Near vision's worse than 2080. We routinely, whether that be pharmacological, whether that be spectacles or contact lenses or post-surgical, uh, we don't push our patients to 2020 at near. It's a misleading task that in many cases creates a situation where our patients feel dissatisfied because they can't read that bottom line. And we live in such a competitive society, we all want to see the bottom. By getting them to 2040, I know some people use cell phones. What is functional vision? And I think when we think about that, we really need to realize that's so important because it, any correction at near is a trade-off. And we're going to delve into that a little bit. But I want to minimize that trade-off. And one way I do that is by not overplussing our patients to give them such great near vision that they never need at the sacrifice of their distance. So, is there an unmet need in presbyopia? I would hope, without question, um, that all of you would understand there's an unmet need in presbyopia. And I go back to the and solution, and this is one of the biggest takeaways I can give you from today's presentation, and was really a driver for me in my office. I had gotten very bad maybe 5 or 6 years ago. I would talk to a patient and I would identify their needs, and I would say, would you like contacts or glasses to address your presbyopia? Would you like this or this? And going back to what we talked about, that early active lifestyle that we all have today, patients have an entirely different set of needs and they're used to needing different tools for it. The unmet need isn't necessarily from the technologies that we have available, it's from our in a indecisiveness to provide a variety of needs to meet what our patient has. We have certain limitations, right? With spectacles, if you're wearing a progressive, they've improved a lot, but there's still a channel. You're going to have some restriction of your field of vision. It's going to require some additional head movement, or it's going to be putting on different pairs for different activities. Contact lenses, multifocal contacts, I really feel like in the last 5 years have moved forward dramatically. But when I say that, uh, I'm an emmetrope at distance. I'm 2015. If I'm wearing multifocal contacts, I can tell you that my near is not, or my distance is not quite as sharp as when I take them out. I'm still very functional. I'm still very happy, but I know there's some compromise. And so many of my patients, having had, whether it be depth of focus, multifocal implants, surgical monovision, whatever the case may be, they still see that there's this compromise that exists. We still have room to grow and improve. And pharmacological treatment, it's dynamic. We use it when we want to use it. It's non-invasive. We'll talk about the administration and the benefits of not having frames and lenses on is very attractive to many of our patients. So how do you discuss what may be available? You know, you can ask them, do they want to prefer, would they prefer not to wear their reading glasses? As a rule, most of our patients don't understand that pharmacological treatment now exists, or they think there's only one treatment option and maybe they have tried it in the past. I think the reality is the simple question is, do you have to make compromises to see your near task? Do you struggle at times seeing things up close? Remember, we want to identify the early presbyopes and then bring up the options and make sure you present all the options and say, now tell me about your day. What are your activities so we can tie that together? So we've kind of talked at length here in the first half about how do we identify our patients? How do we talk to our patients about what's needed? But now I think it's really important that we delve into what options are available. And that's really exciting to me. We now have options across this space for our patients. And I think there's real benefit to that. And I'm hoping that creates more excitement as practitioners and patients too. Because, up until recently, if patients were having difficulty, we could try one drop and that was it. It didn't really require us delving in. So I really want to talk about what are the benefits of each, and then we'll kind of come back to where they may fit. Vuity, first drug in the marketplace, is 1.25% pilocarpine. It is a muscarinic agonist that creates meiosis. What does that do? That creates depth of focus. Remember, depth of focus is creating a range of vision inside the eye. Depth of field is outside the eye. It starts very quickly at 15 minutes and lasts for about 6 hours. I'm sure we've all prescribed Vuity and talked about Vuity. What are some of the side effects? There was headache and brow ache that transitioned across for our patients and decreased over time. I think dim vision was a bigger concern with that pupil constriction, not because it was such a big concern, but how we educated our patients. And then there was risk of detachment, as there is with any pilocarpine drug. We can delve into uh, is that really increased or not? I can tell you the biggest way to control that detachment risk is make sure you're doing a proper eye exam before you prescribe the drop for the patient. Closely then came to the market. It is a lower percentage of pilocarpine, 0.4%. So again, depth of focus. It has a unique benefit. 6 hours is not our normal day. I mentioned earlier, average US adult is spending 13 hours on a screen. Well, that's not enough if we have 6 hours of treatment. Vuity did have some white papers published around twice a day dosing. Closely came out and said, look, we know that we can work quickly at 15 minutes and you can use it that second time of the day. We can extend that 6 hours out. We see the same profile that exists because they're both pilocarpine as far as side effects, but as with any medication or most medications, the lower the concentration, the less risk of side effect and the less severity. So Closey really offers us this chance for comfortable dosing of pilocarpine, minimizing the side effects with less medication and that flexibility of twice a day dosing. The most recent drug to the market is Viz, 1.44% aceclidine. It is a cholinergic muscarinic agonist. So it stimulates M3 receptors, but it's unique from pilocarpine in the fact that it targets with great affinity the M3 receptors on the iris with less affinity for the ciliary body. What does that mean? Well, we get meiosis, we get pupil constriction, but we have much less drug actually working on the ciliary body, so we don't tend to create that brow ache, accommodative response that we saw often with Vuity. Um, was less often with Closey because of lower concentration. So now we have a different mechanism. What are the concerns that then exist? Well, this is once a day dosing, but I do want to point out a little nuance to it. Once a day dosing, but you instill a drop, you wait 2 minutes and put another drop in. Again, I'm going to come back to all of these and talk through them a little bit more in detail on how to educate your patients. Once a day dosing, but 2 drops in that period of time. Again, quick duration, and then 10 hours or longer of clear vision. So that once a day dosing really provides us uh, a longer day without putting in a second drop. When we, my opinion, having looked through the studies, that second drop in the morning is very important, not so much for that 15-minute time point, but that 10-hour time point. So we really extend durability when we do that. I would say the biggest issue that we've had here, we've talked about headaches and accommodative response with pilocarpine. Here we have redness on installation that does occur, and like the headaches, tends to get better over time. And then we have a variety of drugs that are currently uh, in the marketplace being looked at, emerging drugs. Um, First is Brimacol PF, which is carbachol with bromodatine. So longer duration, carbachol is a miotic, and then the bromodatine tends to treat redness off right off the bat while improving that miotic state. And then Nixol, phentolamine, it's a non-cholinergic meiosis, so it actually works by inhibiting the iris dilator. So some people, I've heard the phrase, call it a softer dilation or a softer meiotic response. Um, Unique in the fact that you instill it at night and it has a longer duration that occurs for our patients. So, okay, we know we have these drugs, we know they exist. Where do we want to use them and how do they work? Well, you have rapid onset in all of them. And I think we should step back for just a second and say, what does the FDA ask? What does the FDA want to know about any drug that's on the market for presbyopia? What's their gold standard? So they want to see 3 lines or more improvement of near vision with less than a line's uh, degradation um, at distance. That's the standard for all of these drops as they come to market. Okay. What does that mean in the real world? Well, first of all, 3 lines of improvement can be somewhat arbitrary. The worse you are, the easier it is to gain 3 lines. But let's refer back not just back to the 3 lines, but comfort at the end of the day and their improved vision. So, Vuity, and I'm gonna say this as well, and Closey is misnamed on here, and still has its study name, and I want to call that out right now. CSF-1 is Closey. What does that mean for our patients? Well, Vuity was studied only in fake patients um, in the benefit. And part of that was because part of the improvement in near vision could easily be assumed it was because of the accommodative response that we got. Their studies went up to the age of 55. And so we think the accommodation played a part. What does that matter to me? Well, if I have earlier presbyopes, maybe that's something I want to think about to get that benefit. When I apologize because part of this slide is missing. So we will update that and make sure that's readily available to you. Viz is is the newest drop to the market. And its benefit is once a day dosing for an increased period of time for our patients without that accommodative response. And one thing that I really like to call out with Viz that I think is so interesting to me is the fact that um, Viz was studied in our pseudophakic patients. Why? We know there's no accommodative response, and we still saw 3 lines of vision improvement. We know it's not accommodative, it's that depth of focus. So we're not triggering some of those side effects that do occur. Average age in their study was over 50. The cutoff for Vuity was 55. Closey had an increased period of lifestyle. Their average study age was higher. Stepping back for a second, when we talk about Viz, when you instill it, you need to make sure that your patients are very aware that they may have some red eye for the first few days. I think that's so important for us to point out, um, that red eye scenario as it occurs, because it is transient. For most of our patients, it gets better over time. And the key is to educate them. And I always think about the point that when we talk to our patients, if if you tell them something's going to happen and you prepare them, then uh, they see you as very intelligent and they're happy to deal with it. It's when we don't prepare them. So each of these drugs, we should let patients know that you may have some mild brow ache. In some cases, you would develop headaches, um, the pilocarpine family. In in Viz, you're going to have bright red eyes that may appear for 2 or 3 minutes and will get better as it resolves as you use the drop more. You'll have less incidence of headache. And then Brimacol, we're still looking forward to what comes available. So how do I select patients, and how do I think about them? In my world, in today's world, I really think about the two biggest products that exist, Closey and Viz, are the most commonly prescribed. Closey provides comfort on installation. It has the flexibility of twice a day dosing. We may get some of that myopic or accommodative shift that helps us. I've had very many successful patients in this case. Viz steps out. It provides a bigger range for us. It it provides natural vision for our patients, um, minimizing some of the dimming that may exist with pilocarpines, but could still exist, minimizing headaches, but it does have redness on installation. So the biggest things that I want to educate my patients about and make sure that they're aware of would be that the drop will get better over time. Give yourself increased time to work with it. Give yourself a 5 day trial. The second thing I wanted to educate you is what is the specific side effects? And we've dealt into that with those drugs. The third thing is how is your vision impacted? First of all, you may have some dimness in some of these products because your pupil's myotic. I would encourage you not to use this drop for the first time in a dim exam room. I would encourage you to step out and have the patients use it in their routine life. Second thing is it's not about magnification. If you put on readers, everything looks great big and easy to use. Or easy to see because it's magnified. But that's not what happened when you were 20. That's not what happened when you were 25. You could just see clearly. All of these solutions are about clarification, not magnification. And by educating our patients that from day one, we really help them step forward and begin to understand what's available for our patients, how it's going to work, and what their visual experience will be like. So stepping back, what do we need to monitor? What do we need to see for our patients? How do we want to prescribe for them? And how do we want to address what exists? First of all, I cannot stress this enough, and I feel that we have great partners currently in this space helping us educate our patients. These patients need to have a peripheral retinal exam before you prescribe. We know um, that there could be increased risk of vitreous detachment. We know that we want to minimize for our patients what's happening and the opportunity that exists for them to have any kind of complications. A comprehensive peripheral retinal exam is the key component of that for me, however your office chooses to do that. Another rule of thumb to think about, um, as a rule, your risk of retinal detachment at -6 increases exponentially. That's so important. I'm hesitant, even at this point, to think much above the -6 prescription range. And then we need to identify and communicate with our patients not only their needs, but what are the side effects that may exist: headache, dim vision, irritation, and the fact that that's transient. So, education, peripheral retinal exam, understanding of the patient's needs, and then the proper selection that exists for our patients. So, currently, uh, we have 3 products on the market that exist for us. We've talked about the strengths of each. There's 2 other products coming, Bremacol and Nixol, that should be on the market soon. And then we have future extended release combinations. Optometry's role is to identify lifestyle driven candidates. And so let's go back to what I was discussing early on. There's 128 million presbyopes in the United States. Of that 128 million presbyopes, I think as optometrists, we tend to routinely think that we need to make sure every patient embraces every technology that we offer. We feel incomplete if we're not giving the patient the best possible product, and that every patient accepts what we say immediately. Remember, this is an or solution. It's an opportunity for us to provide the next option for the patient, and not every patient is going to accept what we do or think that this is the perfect answer. It's okay to fail, but you've provided the opportunity to the patient and you've created that loyalty. Don't be afraid to try, is my point. Even if we capture 3 million presbyopes out of 128 million, we've changed the game and we've elevated our practice. When it comes down to prescribing the drop, once you provided those baseline exams, I really think it's giving the opportunity for our patients to see that. We have heard some discussion in the past about, do you see an increase in floaters? That tends to be uh, variable for me. Most patients tend not to notice it. Dimming vision is something that most patients work through. But I think we also now have the opportunity to pair this product in the best possible way for each patient, just as we would treat dry eye or whatever that scenario may be. So Viz versus Closey would be the 2 newest drugs to the market and offer us a wide expansion and a wide range for our patients to move forward. Just hitting this, I think there's uh, clinical considerations for both. I will tell you, intermediate vision is great in both. Intermediate tasks tend to be wonderful in both, as well as tolerability that exists. We've covered the new drops that are coming to market. I think Occufier also has claims that exist around being night vision friendly, and how is that impacted in our day-to-day life. Brimacol has a FDUFA date of January 2026, so we'll soon be seeing where that's at. As we begin to wrap things up, I think we need to really think about how we manage our patients and what opportunities we provide them. First of all, is the patient management evaluation, and we've covered that at length. Making sure we tell the patients exactly what the product's going to be like for them. What is it like on installation? What are the benefits they receive? And then what are the follow-up appointments like? Uh, it's interesting. When I only had one option, follow-up wasn't such an important part to me. But now I realize I'm tailoring these products to my patient. Follow-up can be more important. I first select the best product I have available for my patient. whether I think that be Viz or Closey. I provide that product and I give them a period of time and ask them to use it every day. Once they've become adapted to it, they can then choose days to use it or not. But I really think that 5 to 7 day run in is a key component to again learn about clarification versus magnification. Once that's happened, we have a touch point in my office. My staff will call and follow up. We send the script the same day we provide the sample. Um, if the patient is uh, not satisfied with our initial selection, we do bring them back because we have other options available. If the patient's satisfied, they've already received their prescription, and we know that this could be an everyday drug for some patients and a sometimes drug for other patients. Routinely in my office, we see this patient one time a year um, and provide the prescription. We also think that there's real benefit to tying them to purchasing other materials in our office. So know what the treatments are. Be familiar with the options that are available and how you can address the needs of your patients and best provide what they need. And as I wrap this up, I am going to apologize because I was flying back today and I was working on this deck and changing a few things, and a couple slides uh, have fallen out of format or related to older versions. And all I can, I offer my biggest apology for that. And I will say that I will make sure and get the correct deck to Wu University tomorrow to make sure that that can be provided to all attendees. And I do apologize for that. I have not had that happen to me, and I am sorry.
All right. Well, thank you so much for that awesome presentation, Dr. Pinar. We have a few questions in the chat, so we'll go ahead and rock through some of those. What are your thoughts on long-term safety with use of these drops? Are you okay with prescribing these for patients for the next like 10, 15 years?
Yeah, I think when you look at both drops on the market today, it becomes very interesting. If they discontinue treatment, they can still be dilated the next day. In, in many cases, even after they've been on the product for a year. So we know we're not creating synechia, we're not causing that long-term risk or concern that we would think of. So yes, I am comfortable, and I also think in the next 10 years we'll continue to see this marketplace evolve.
Right. And one question was patients that have had refractive surgery, how do you know if they were high myopes and when you might want to be more cautious about prescribing some of these drops to them?
Well, more cautious in the fact I'd like to know their pre-surgical refraction. Um, Three ways to look at that. One is a records review. Axial length becomes a big driver that we can refer to. And in absence of those, I think you have to do an extensive dilated fundus exam and make sure that you don't see changes on the peripheral retina. Um, those
Great.
things alone, I think, eliminate the risk.
So one comment was one of the doctors on said that they are 71 and use Viz and are 2020. And they asked, what are your thoughts on using Lumify for patients that may have potential redness?
I think there's real benefit to that. I think that offering Lumify to your patients, especially in the first 5 to 7 days, when they may have more redness with Viz, is a great solution that we implement for our patients who have concerns in our office. I think the
Great,
fact that they're 71 and are seeing 2020 at near, is a big testament to what this method, this modality of treatment can offer our patients.
for sure. Another question was, can any of these drops be used off-label for nighttime glare when driving?
So Nixol has been looked at extensively for nighttime driving, um, and we can see there's data out there that supports the benefit to our patients. I think with the other medications, it, I've clinically had patients come back and say their night driving is better, especially after being on it a week or two and maybe becoming used to that slightly dimmer. So Nixol would be the biggest drop that falls in that space, but I think you can see both or all drugs that are currently being looked at can have benefit in some patients. One thing I should have mentioned, as with any miotic, the biggest thing you want to look for is any central opacity, right? So if there's a central scar, a dense cataract centrally, and you create a miotic pupil, you exacerbate the effects of that. And so that's a concern. But that's the biggest thing I look for.
There's actually a question on if a patient had like a multifocal IOL, if you think that that would impact their vision.
You know, that has not been studied yet. So I would encourage the practitioner to think through uh, the the design of that lens, the myotic pupil, and how it may benefit or hey, maybe cause some degradation of their vision. Um, but I think that is a really interesting space that there could be great opportunity for us.
Then I'm going to combine a few questions. One was how you instruct patients to use this drop when they are wearing contact lenses. And if you knew that you were going to have them on one of these drops, would you just prescribe distance contacts as opposed to multifocals?
I think that's such a wonderful bridge for us. I talked about the trade-offs that exist with contact lenses or switching to progressive lenses or whatever that scenario may be. And when you look at that, uh, there's a trade-off. So these products could very easily offer us an opportunity to keep our patients in their single vision correction longer, provide natural vision, distance and near, um, and not make the compromise that exists with those other corrections. So I most definitely would look at it for patients with uh, single vision contacts. Uh, in my practice, I think the discussion is make sure they wait 15 minutes to put the contact in after they've instilled the drop. And the logic for that would be we don't want to create a reservoir for the drop, so we want to give them a period of time for absorption to occur. But once they've done that, I think there's a lot of opportunity.
Actually did that today for someone. I was going to move into a multifocal scleral, and I was like, let's just prescribe this drop instead.
Yeah, and from a patient perspective, there's a lot of benefit, and again, I come back to if we create this, it's about clarification, not magnification. It's much more real world vision that exists for our patients.
Right. Um, what signs in the retina would prevent you from prescribing some of these drops?
Um, Areas of concern in the peripheral retinal, VMT, vitreomacular traction, lattice, any peripheral degeneration that existed. Um, I say this is a big embracer of new technology, but I think the answer is it is still new technology. So err on the side of caution. If you have doubt, wait. Again, there's 128 million presbyopes. Explain to your patient why you're waiting. And as we see a more robust data set evolve, I think we have real opportunity um, to tailor that and know what's more concerning. But for right now, any peripheral retinal change, high myopia, vitreomacular traction, I'm going to hit the brakes for a few minutes.
Hmm. And when you prescribe some of these drops to patients, say that they're a -2, -3, are you still talking about some of those risk factors of, like potential for retinal detachments? Or are you mostly focusing on, maybe expect your eyes to be a little bit red for a short period of time?
I feel like you asked two questions there. I'm going to focus more on, hey, there's redness, there's dim, maybe some dimness in your vision. That's my bigger focus. At the same time, I'm going to say, as with any medication, there could be side effects with your script. They may be exceedingly rare. But if you notice an increase in flashes, floaters, distortion in the periphery, the significant, please let me know. So I'm going to
Mhm.
mention it, but my focus is going to be different in that patient than the -5 patient.
For sure. Okay. How are you finding insurance coverage is going or
Well, it's not.
coverage in general?
Yeah, it's not going, and we need to be aware of that. Again, with most of the anti-aging things, they're not covered by insurance, and there's a lot of our patients that are willing to make that investment to feel younger. So you don't have to worry about prior authorizations because you won't have to deal with that. There's a plus, but there won't be insurance coverage. Um, and that also becomes when you schedule your follow-up, are you seeing the patient back for another reason? Then you can discuss this. But if not, currently, that follow-up is not something that's going to be covered by insurance.
Hmm. Let's see here. Do you have a cap on hyperopic prescription or astigmatic prescriptions?
Not on astigmatic. Now, obviously, the higher they are uh, uh, with astigmatism, the much more you have to have correction in place for the astigmatism, right? But I'm not concerned about that. I look at the spherical equivalent as far as myopia. As far as hyperopes, again, there was gonioscopy mentioned on a slide. Make sure that they have an adequate anterior chamber, and then I have minimal concern, more than a set
Okay.
number on script.
One question was, I have a patient who is amblyoptic, 20/60 in one eye. Will Viz work for near vision if it is used only in the better eye?
So it could. Now, some of these studies have reported monocular data, some have reported binocular data. Uh, it it could, and I think there's real potential for that, and I would not be afraid to try it in that patient. To say that I have done that, I can't answer that question. The other question I routinely get when I talk about presbyopic drops um, is the question of uh, do I just have the patient use it in one eye? All the studies are bilateral dosing, and that's the experience we've had in our practice. Again, I think as we move forward with the product, we'll see more discussion that allows us to look at that for our patients. But right now, all the patients we've treated are binocular.
Okay, great. Let's do this as the last question. And for the other questions that we have in the chat, we will be able to connect you guys next to the sponsor room, and we'll be able to answer a lot of questions on like specific costs and pharmacies. So please be sure to join that room, and we can ask all of those more specific questions related to Viz. But the last question for you would be, what makes you decide whether to suggest progressives to a patient versus these drops?
Well, let's let's go back to early in the discussion. It's not an or question, right? It's an and question. So I'm probably going to suggest that the patient have progressive lenses if they're in need of those. But I'm also going to say here's another opportunity that exists for you. Um, as a personal example, as I mentioned, I'm an emotrope. I have great distance vision. Um, I love this drop on one of these drops when I'm out uh, golfing, when I'm working outside on the weekends. Those benefits are real to me. It's an and solution. So I would suggest both to patients and tell them the benefits of both. And even if they don't take both that day, they may take both as they move forward.
Okay, awesome. All right. Well, thank you so much for sharing all of your knowledge with us. We really appreciate it. We've already had some great feedback in the chat.